So I'll be presenting with Dr. David Braun as well. So just to understand the kind of the landscape of melanoma care and the recent clinical developments, this is kind of the spectrum of systemic therapies that have been approved. And then more recently with the approval of lifileucel last year, which was our first cellular therapy that was approved in melanomas. So actually there was a 5-year update at the ASCO annual meeting of C14401 that presented 5-year survival data for the lifileucel therapies. So the overall response rate was 31.4%, complete response rates of about 6%, partial responses of about 26%. There was significant tumor reduction in a majority of those patients. And actually the interesting thing that they presented in terms of the spider plots was that even 3 years into this one-time treatment, there was a deepening of responses. So a lot of these patients who had a partial response eventually developed, a handful developed a complete response 3 years plus down the line. And responses at 3 years were very durable. 31.3% had ongoing responses and overall survival was nearly 20%. The median OS was about 14 months. One of the other updates that was presented, again, was from the DREAM-seq clinical trial. This was really a question about sequencing of systemic therapies for patients with metastatic disease. We have targeted therapies that inhibit BRAF MEK inhibitors, and the question was, were those oral therapies any better than systemic immune checkpoint inhibitors? And so this was a large phase 3 randomized clinical trial that put people either with ipi-nivo frontline, followed by the option of continuing on to dabrafenib trametinib after progression versus upfront dabrafenib trametinib followed by ipi-nivo at the time of progression. The 2-year overall survival data was 72% with upfront immune checkpoint inhibitors compared to 52% with targeted therapy. And so the updates that were presented do show that ongoing overall response rate was still persistent at 5 years. So the 5-year OS was 63% with upfront immune checkpoint inhibitors compared to about 34% with targeted therapy. When you also look at progression-free survival as well, compared to 2 years, 3 years, or 5 years, there was still an ongoing superiority of immune checkpoint inhibitors compared to targeted therapy. When you analyzed by subgroup and clinical demographic information, so gender, age, performance status, stage 1C disease, and LDH status, there was a clear superiority across multiple clinical subgroups by PFS and OS for the individuals treated with upfront immune checkpoint inhibitors. So really frontline ipi-nivo has really kind of been the standard of care, which helped confirm what we knew all along at Yale. When we evaluated brain metastases, though, so this was an interesting kind of analysis that was performed and presented at the annual meeting. So frontline ipi-nivo resulted in actually improved brain metastasis-free survival. And so hopefully fewer jobs for Dr. Veronica Cheng to have to treat. So really these individuals at 4 years, the individuals treated with upfront ipi-nivo had a 76% brain metastasis-free survival compared to only 62% in those treated with targeted therapies upfront. So those were the kind of the clinical trial updates for previous studies that we were aware of. In terms of kind of redefining sequencing of therapies, there was a lot more discussion about adjuvant therapies and new adjuvant approaches for the treatment of melanoma. So kind of the standard dogma, 15 plus years ago was surgery followed by surveillance. Obviously, a lot of high-risk patients relapsed. Then came the era of adjuvant therapy. And so in that setting for stage 2B and C melanomas, pembrolizumab and nivolumab have already been FDA approved. There was an update on the Columbus AD trial that looked at Incobeni in the stage 2B, 2C setting, which did show at 12-month analysis improvements in relapse-free survival, and as well as distant metastasis-free survival as well. In the stage 3 and resectable stage 4 setting, we have 3 separate approved indications of pembrolizumab, nivolumab, and dabrafenib and trametinib. There was additional updates regarding the combination of nivolumab and relatlimab that did not show any improvement in relapse-free survival compared to nivolumab alone. And so this was presented in the Relativity 98 study. And so we'll further talk about a lot of the sandwiched approach, meaning neoadjuvant therapy followed by surgery, and then potentially risk kind of response adaptive consideration of adjuvant therapy. Really, the central 2 studies that have moved this field forward have been the SWOG 1801 and the NADINA trial, which have been previously presented at prior meetings. The SWOG study included pembrolizumab for 3 doses followed by surgery, which showed a pathologic CR of 21% and tolerable, acceptable toxicities of 12% with grade 3. Then came the NADINA trial, which included IPI-1 Nivo 3 for 3 cycles, for 2 cycles followed by surgery, and then response adaptive considerations for the additional of adjuvant therapy, which can be further immune checkpoint inhibitors in terms of Nivo monotherapy or a BRAF targeting agent. The major pathologic response in that study, which is considered as less than or equal to 10% of remaining viable tumor cells, was 59%. And so that's really become the new standard of care for people with clinically node-positive disease. So there were a number of neoadjuvant clinical trials that were presented, most of which were very small studies. One of them was the NeoActivate Arm C, which evaluated atezolizumab, anti-PD-L1, and tiragolumab, which is an anti-TIGIT for 4 cycles. And so this is 3 months actually of treatment. The major pathologic response rates with this trial were 47.7%, so still inferior, given the defects in cross-trial comparison to the NADINA study. There was also data from the NEO-MEL-T trial of dostarlimab, which is an anti-PD-1, versus dostarlimab with cobalimumab, which is an anti-TIM-3. The major pathologic response rate was still inferior to NADINA, 33.3%, with dostarlimab alone versus 55.6% with the combination. Then there was the EA 6194 clinical trial, which looked at pembrolizumab alone versus an injection of a vidotulimod sub-Q followed by intratumoral injections. So that's a TLR9 agonist. It's thought to increase type 1 interferon responses. The major pathologic response rate with the injection and pembrolizumab was 79%. However, all these other prior clinical trials used solely systemic therapies, not intratumoral injections, and so a little bit difficult to fully evaluate that response. Finally, there was a CIT clinical trial of IPI-3 Nivo 1 for 1 dose, followed by surgery, and the major pathologic response rate there was 53%. All right, so we all know that major pathologic response rates are really indicative of long-term improvements in survival and distant metastasis-free recurrence. And so this is kind of showing complete responses versus a near-path CR, which is what we consider a major pathologic response. One of the additional clinical trials that I just wanted to highlight, which is an early phase clinical trial, is IMA 203 run by Immatics. This is a phase 1 auto TCR-T targeting PRAME study in individuals with PD-1 refractory melanoma. And I wanted to highlight this given the kind of remarkable responses seen on this, again, very small early phase clinical trial, but something to look out for in the future. So this basically targets intracellular PRAME-derived epitopes presented by HLA-0201. So the individual had to have HLA-0201 as well as PRAME positivity. 33 patients were enrolled with a median follow-up of 14 months. Overall response rates were 56%, with durable responses of 12.1 months. Median PFS was 6.1 months, and median OS was 15.9. Because of this data, there's ongoing phase 3 clinical trials evaluating this agent. So this is a novel engineered T-cell cellular therapy. This is kind of the schema of treatment here. So again, patients must have HLA-A*02:01. They must have a tumor that's PRAME positive, which most melanomas are, particularly uveal melanomas. So the patient gets peripheral leukapheresis to collect T cells. Then those T cells are engineered. Then the patient comes back for lymphodepletion, followed by one infusion of the IMA203 engineered T cells, followed by low doses of IL-2. So kind of very similar to lifileucel or Amtagvi. And so what was notable about this clinical trial was particularly the response rates in uveal melanomas. And so this is a disease that has been very cold immunologically and very refractory to our standard immune checkpoint inhibitors. And so with this novel therapy, 67% overall response rate, which is quite remarkable. In addition to this, the duration of response was also durable. And again, kind of the median progression-free and overall survival graphs for your viewing. I didn't know whether we were doing CMA questions, and I'm happy to skip this for the purpose of time, or we can do it. Okay, perfect. Okay, all right.
Okay, so Dr. Braun is going to talk about renal cell. Thank you, Dr. Tran. And just to point out that that IMATIX trial is open here in New Haven.
Hi, everyone. I'm going to give a quick whirlwind tour of some of the most relevant clinical scenarios for medical oncologists for kidney cancer. So the first is the adjuvant setting. So the long-term follow-up from Keynote 564 was presented. This is the first and only drug in the history of RCC to have an overall survival benefit in the adjuvant setting, and that benefit is maintained now at the long-term follow-up, the 5-year follow-up. But you can see here, so I frequently use that in my practice, but we can see that many patients still experience recurrence on adjuvant pembrolizumab, and so we're trying to do better. So one of the trials we have open here at Yale is trying to build on success of adjuvant pembrolizumab through the Alliance Strike trial, and this is basically a randomized trial of pembrolizumab with or without a short course, a 6-month course of tivozanib, potent VEGFR targeting tyrosine kinase inhibitor. So that's the adjuvant setting. Now in the first-line setting, we have remarkable long-term follow-up, 9-year follow-up from IPI plus Nivo for first-line metastatic clear cell RCC. We see overall survival, progression-free survival, and I would say most remarkably, the duration of response curve on the right, we can see that if someone were to obtain a response with IPI-Nivo, 50% of those patients are still responding 8 years later. And so there's many options in the first-line setting, but our group tends to use IPI-Nivo because of this long-term durability. But there's certainly a lot of room to do better. We see there's a lot of patients that still don't respond. And so we have currently open the Architect trial run through the Hoosier Cancer Research Network. This is a randomized trial of IPI-Nivo versus a sort of next-generation version of CTLA-4 blockade, botensilimab. And so this is currently open and accruing at Yale. Moving on from the first-line setting to the refractory setting, we've seen belzutifan, the HIF-2 alpha inhibitor, really sort of take a place in the treatment of renal cell carcinoma. But there's a new potent HIF-2 alpha inhibitor, casdatifan, which has really interesting data in the phase 1 trial, this ARC-20 trial in combination with cabozantinib. In this refractory population, response rates of nearly 50%, and as you can see, many of those responses are ongoing. And so here at Yale, we're exploring this in a phase 3 trial, the PEAK-1 trial, which is a randomized trial of patients who would get cabozantinib with or without casdatifan, this potent HIF-2 alpha inhibitor. And finally, I think Mike Hurwitz might have already mentioned CAR T cells are taking a place in renal cell carcinoma as well, targeting CD70, but the world of antigen-directed therapies is vast, including CAR T cells, but also T cell engagers. And this was the ALLO-316, the TRAVERSE trial, a trial that we had participated in. But moving forward, there's multiple opportunities for antigen-directed therapies for patients with refractory RCC. A T cell engager through Xencor, targeting ENPP3, and also additional CAR T cells that Mike Hurwitz has certainly talked about. So with that, really exciting developments in the adjuvant setting, first-line metastatic and refractory setting, and if there's patients who are interested in clinical trials, we do have clinical trials for all of those clinical scenarios. Thank you very much.
Thank you, Dr. Braun. Does anyone have any questions for Dr. Tran or Dr. Braun? Okay, that means they gave a very clear presentation.